So how can we, I had to say spread the word, but it was a struggle when I changed physicians about 4 years ago. My doc retired, we changed practices, and she was a breast cancer, but she did a lot of myeloma. She was a transplant physician, so probably only about 40% of the practice. So I brought my retired physician's practice with me, and so now we're about 80% breast, which I love because myeloma is just not that much fun to treat. And so having that discussion. So what has your experience been with your APPs in the clinic or your physicians in saying there's real data behind this?
Yeah. Well, we've hired a few newer nurse practitioners, and they have a lot of oncology RN experience, and they're often reaching out. You know, Marla, what do I do with this patient? What would you do with this situation? I had one, Robin reached out to me about 2 weeks ago, and I said to her, run BCI. Run BCI. That's going to tell you what you need to know. That's going to tell you risk of recurrence, and it'll be comfortable for the patient to understand, and empowering in a lot of ways, to understand the risk and what she needs to do, whether it's stopping the medication at 5 years, pushing through for 10 years. So a lot of education, especially with our younger nurse practitioners.
Guiding and mentoring is very important. And so, I do a lot of preceptorship, and I start, at that level, because since we are in the clinic, we're going to be ordering it. I start the seed, like you said, at that point. So definitely. Also, our ONS meetings, are very important to let them know, where we go from here.
So I think by nature, we're all teachers. I think that's one of the strengths of APPs. And I think, in my experience, APPs are much more comfortable leaning on each other. So here are the guidelines. This is intended to help us make that decision about extended endocrine therapy, those 3 to 5% of patients that benefit. Who are they? Because you don't want to treat 100% of patients just to pull out that 3 to 5. It's like giving chemotherapy before Oncotype. This helps discern who those patients are. It is the test. I mean, it says most commercially available, validated. It is the test. It is the only one in NCCN and ASCO guidelines to help us make this decision about extended endocrine therapy.